All right, wanted to give the lecture for Unit 3 here, which is about Chapters 7 and 8. So we'll start with Chapter 7, Diagnosis and Classification Issues. And so you can follow along with me on the PowerPoint if you like, or just listen here. First of all, when we talk about diagnosis, we've got to talk about normality and abnormality. And this is a big challenge, so we're going to be talking about what it is and who gets to define it and why it would be important to define it. So, when we try to decide when is somebody abnormal, what are the parameters? What do we use to determine that? So some people would say, well, if the person's in distress, then we know that's a problem. Others would say, well, if it's different from what everyone else is doing, that's a deviance. If it doesn't happen very often, that's the statistical infrequency. Or if it's impairing their social functioning. For instance, with personality disorders, the person feels like, I don't have a problem, everybody else has a problem. But what it comes down to is their interpersonal functioning is not where it needs to be, or is not satisfying for them. So we would consider that perhaps a diagnosis. So more recently, we want to look at both the scientific data in terms of dysfunction, what's not going well, and the potential social context, as what they're doing harmful. For example, can some behaviors be actually normal in the sense of culturally typical, but still be considered abnormal or maybe harmful? For instance, this constant texting and being in electronic devices, that's pretty normal in this society, but is that really psychologically healthy to be sort of doing that constantly? So who gets to define what's abnormal? Well, at the moment, the DSM, which I have right here now in the 5th edition, the Diagnostic and Statistical Manual of Mental Disorders, published by the American Psychiatric Association, is sort of the official book that's most often used, although there's a lot of controversy about this book, as we'll talk about. That sort of has a listing. Now, because it's created by the American Psychiatric Association, it naturally has a medical model that it's based on. And medical models are based on pathology, what's going wrong. Tends to be, categorical as well. This, just like a disease, either you have a disease or you don't have a disease. So they've been applying that to mental health disorders. Either you have this disorder or you don't, and we'll talk about the problems with that. More recent editions have included more other types of individuals, psychologists and social workers, etc., but primarily it's still psychiatrists. So why would it even be important to be able to define abnormal and give diagnoses? Well, labeling what somebody's going through as a disorder definitely has an impact on us as professionals as well as on clients. And we'll talk about that in just a moment. And the DSM, by the way, also has in the back, it's called Emerging Measures and Models section, where they're looking at some not the potential disorders. They're not really official, but hope to inspire future research. So anyway, why is this important? So for professionals, it can be helpful to facilitate research, awareness, and treatment. For example, if we don't have diagnoses, and every single person I see, I've got to sort of start from scratch, and I wouldn't be able to draw on the research that says for depression we know this is the most effective treatment, or these are things to keep in mind. Of course, the danger of that for professionals and for clients is then we put them in a category, we pigeonhole them, and we don't see all the other factors that are individual to that particular client. And there's some good things for the clients. One is that it demystifies what they're going through. In other words, if they've never experienced depression, for them to have a label and say this is clinical depression, major depressive disorder, helps them realize, wow, it's not just me. I thought I was the only one. I thought there was something inherently wrong with my being versus I'm just suffering from depression. By giving it a diagnosis, we acknowledge this is a serious thing, especially something like clinical depression. You don't just kind of get over it the next day. This can be something that really needs attention. Of course, once you have a diagnosis, it gives you access to treatment and potential reimbursement by insurance companies, etc. Now, of course, there can also be some damage from being labeled. You suddenly get a stigma, or people associate you with your label instead of seeing all the different aspects of who you are as a person. And sometimes there's legal consequences. I have my pilot's license, and whenever I go to get that renewed, they have to assess if I have any mental health diagnoses. And it doesn't necessarily mean you can't fly with that, but there are certain things to keep in mind. If you want to be a police officer, a firefighter, etc. Sometimes these labels can cause some damage. I don't want to get too much into the history because there are other courses that go into history, but basically there are many editions. As I just said, the DSM is now in the 5th edition. We'll go into some of these a little bit, but before the DSM, all kinds of theories about fluid imbalances. Pinel proposed some categories back in the 19th century, and a few started to be put out by Kreplin. In the mid-1900s, the military decided to start putting out some labels, shell shock, etc., for soldiers returning from World War II. And they were categorical in these early systems just to try to get some statistics about what was going on. So the first edition was published in 1952, and then it went through some updates. I don't think we need to go through each one of these, so let me actually jump ahead. The one I started with was the DSM-4 TR, and the TR stands for text revision. It was really the same as the DSM-4 that came out in '94. They just updated some of the statistics, etc. But in 2013 is when the DSM-5 came out. There was a lot of controversy, as I said, about this book. Some people claiming they just refused to use it. There's also ICD is a international classification of diseases, which is published by the World Health Organization. But that one is really just a list. It doesn't give you the detailed requirements and symptoms, etc., that the DSM gives. So it's almost like a monopoly at this point as far as where the diagnoses come from. So it was shaped by a task force and work groups, and right in the beginning of the book you'll see lists of all the names of the people who contributed and their degrees, etc. And they also wanted to get more consistency with this edition with the international classification. Here's a list of the changes that the DSM-5 did not make, despite some people's wishes that things get changed. One is there's not much emphasis, if any, on neuropsychology, and which is getting much more sophisticated, and we'll talk about that in a future unit. It also did not make a change to a dimensional definition of mental health. In other words, it's a category. As I said, it's yes or no, either you have it or don't, versus you're somewhere on a continuum. We'll talk about that. They also proposed that for personality disorders, but in the end they ended up keeping exactly the same personality disorders that they've always had. And they didn't remove any of the personality disorders. And there's still some emerging measures and models that didn't switch over to becoming actual disorders. There's a typo in the slides here. The title now, this minor thing, but you'll notice that it has a number 5, whereas all the other editions have Roman numerals, 1, 2, 3, 4, because their idea is that this could become, with the electronic age, 5.1, 5.2, etc. The other change, if you are familiar with the previous DSM, is they no longer have that 5-axis diagnostic system. You just write down what's of clinical concern. You don't have to go through all 5 axes. And if that means nothing to you, then you don't have to worry about it. There are some new disorders now listed in DSM-5. And again, this is part of the controversy is do we need to keep adding new disorders? But and especially one, premenstrual dysphoric disorder, obviously has some potential gender bias there. But for some people, they determined they felt it was strong enough to warrant giving a label so it could get attention. There's disruptive mood dysregulation disorder, which basically is what used to get labeled as bipolar disorder for kids. There was so much controversy about kids really shouldn't have bipolar, and it manifests so differently in kids. It's very rapid with kids, whereas for adults it takes months to go through cycles. So they now call it disruptive mood dysregulation disorder for kids. Binge eating disorder has now been separated out from bulimia, so made its own category. Mild neurocognitive disorder, so just for it's a less intense version of major neurocognitive problems like dementia, Alzheimer's, etc. This is where you just have more mild versions. Maybe you suffered a head injury in a car accident, and it's not really severe, but significant enough that it's affecting your life. Somatic symptom disorder, where there are just certain body things going on that get excessive focus. And hoarding disorder used to be listed under, and it's still categorized under obsessive compulsive disorders, but it's been given its own name now, or separate diagnosis. Some other diagnoses got revised in the 5th edition. One is that it used to be for major depressive disorder or an episode. It said if it's caused by bereavement or grief from someone dying, then it's not major depression. But they took that out because it's possible, even if it's a reaction, it's a grief reaction, that somebody gets still so depressed they want to be able to still call it depression and get treatment for it when it's appropriate. Another thing is that there used to be a separate disorder called Asperger's disorder, which basically is mild autism, and they removed that label, much to the chagrin of many of my clients with Asperger's disorder, and now it's just autism spectrum disorder. So you've got mild end, which used to be called Asperger's, and the more severe end, etc. Also, for ADHD to be diagnosed, you had to have the symptoms present before the age of 7. So if you suddenly developed attention problems later in life, that's not ADHD. It must be some kind of other brain problem. You're sort of born with ADHD, if it's true ADHD per se. But it can be really challenging to figure out, did somebody really have those symptoms before the age of 7? And sometimes it doesn't show up because you don't go to school much before that, so maybe it doesn't show up as much. So they raised it to age 12. If you had symptoms of ADHD anytime before the age of 12 and still have them, then that diagnosis can be given now. And in bulimia, it used to be that you had to have binge eating twice a week, and they decreased it to once per week, still counts. Another thing is that they used to have 2 separate categories, substance abuse and substance dependence. And the difference was for dependence you had withdrawal symptoms and etc. Abuse could be occasional, but those became really hard to distinguish at times, so they just combined it into substance use disorder now, so those 2 things are not separate. Mental retardation has been renamed intellectual disability. Those words have become overused and misused and sort of strong put down. So it's called intellectual disability now. Learning disabilities are now specific learning disorders. In other words, a reading disorder and writing disorder, etc. OCD used to be listed under anxiety disorders, but now it has its own category of obsessive compulsive and related disorders like hoarding disorder. And mood disorders are now split into two categories. It used to be depression and bipolar disorder were all in the same category. Now it's depressive disorders and then a separate bipolar and related disorders category. So as I mentioned, a lot of controversy over DSM-5. There was a whole lot of emails back and forth and people protesting and saying they're not going to use it. And one criticism is that it just keeps increasing the number of diagnoses, you know, and eventually everything's going to be a diagnosis, some people would say. Other people would say, well, but we want to be able to more specifically help people with specific problems. Another criticism is that there wasn't much transparency. You know, science is meant to be an open public process, but a lot of the DSM-5 work was done behind closed doors, and what was shared with the public was kind of vague and selective. Another criticism was the membership of the people that created the DSM-5, because predominantly they were researchers, not clinicians. So clinicians are the people actually out there doing the work in the field. And we would hope they would get more input into this process. There are also some problems with the field trials, the reliability, as we'll talk about in the next lecture, the next chapter. The reliability ratings were considered kind of low. Another thing is the price. This paperback I'm holding in my hand cost $150 and almost $200 if you get the hardback book. So it's quite expensive just to even get a copy of the book. And again, maybe there are just too many disorders, another criticism, right? Are these really mental illness? Are we stigmatizing people by creating all these labels? Are we making so many that it becomes trivialized? Also, the cutoffs for what decides whether or not you have the disorder in some ways are kind of arbitrary. You know, how many symptoms do you have to be in that category, and who decides that? It's not always scientific. Who gets to decide what's significant distress and impairment? Because it has to be significant distress and impairment to be considered a diagnosis. And there's still some cultural issues. Even though the later editions have been getting better about paying attention to diversity issues, it's still an issue. As I mentioned a little bit ago, there's still some gender bias. Are there some categories that seem to pathologize one gender more than another? For example, some diagnoses happen more often for males: alcohol abuse, independence, substance use disorder, conduct disorders, ADHD, antisocial personality disorders. And there are some diagnoses that women get more often: mood disorders, anxiety disorders, eating disorders, borderline personality disorder, histrionic personality disorder, etc. So are those real differences, or are those social differences? Are those really just biases and pathologizing? Sometimes the same behavior by both men and women are interpreted differently, of course, by our culture. Another criticism of the DSM is just some of the non-empirical influences. In other words, the politics and finances involved in deciding what's normal and abnormal. And again, some of the limitations on being objective. So even if there's more science, are there still a whole lot of opinions and just plain judgments in deciding who's normal and abnormal? So what the DSM is doing, as I mentioned before, it's a categorical approach. All these diagnoses are categories. So do you have this disorder or not have this disorder? That's sort of a black and white approach with no shades of gray in between, yes or no. And it makes it easier to talk about. You know, if somebody has depression, then we know they have depression, and here's the treatment for depression. Of course, the downside is that no one is, you know, even people with depression are all very different. So there's been proposed a dimensional approach that did not happen for this current diagnostic book, but you know, instead of saying somebody has it or doesn't have it, can we look at a continuum? So here's an extreme, here's a milder end. Where does the person fall on this continuum, let's say with anxiety? And one potential set of dimensions could be the 5-factor personality, neuroticism, extroversion, openness to experience, etc. These different categories of personality could be one way to do that, but it makes it difficult because then everybody's going to be different. So how do we communicate about clients? How do we research what treatments are best? So it may be better suited for some disorders over others, for instance, personality disorders, because everybody has dementias of personality. So that's chapter 7. So let me bring up the chapter 8 slides for myself here if you want to follow along. I'm now in the chapter 8 slides. So chapter 8 is about the clinical interview. So this is pretty much the first thing, you know, we do with all new patients or clients is just sit down and talk with them, do an interview. And the interview is considered an essential piece of assessment. And for clinical psychologists, assessment is really our big strength. Other professions can do therapy. Other professions focus on medications or what have you, but psychologists are the only ones that are legally allowed to do a lot of assessment in terms of neuropsychology testing, IQ testing, and personality testing, etc. There's some variation on that depending on how powerful the state board is for the other professions. Some of them are trying to get in on that, but for the most part, psychologists' strength is really diagnosis and assessment. So the interview is really the strongest tool. Now, I've done a whole lot of psychological testing. I've done neuropsych testing, but now that I'm in private practice, the most frequently used assessment tool is just interviewing, sitting down and talking with the client and knowing the right questions to ask to get at what's really going on. Now, as we'll get into here in just a moment, especially when we get into other more objective assessment instruments in the next couple of units, or the next unit anyway, there's some important things to keep in mind. One is called validity, and what that means is if I give somebody a test, is it really valid? Is it measuring what it says it's measuring? So if you go online and take, you know, how good of a lover are you test online, is it really valid? I mean, if you take that test and it says you're a good lover, you know, how do you know that's really true? That test would have to be validated by, maybe I shouldn't use this example because this could lead in all kinds of other places, but you'd have to have people, you know, rate your loving ability, or, you know, have some kind of how many orgasms you give your partner, you know, some kind of criteria. What really makes that test accurate and valid in terms of measuring what it says it measures? Reliability is another important piece, and that is, does it give consistent, reliable results? So you could take that how good a lover you are you, you know, test and get a high score, and then a couple weeks later you take it again and it gives you a low score. So that's not a very reliable test, because I would hope in a couple of weeks your ability to, as a lover, doesn't change. So it really shouldn't change that much. If it's reliable, it'll keep giving you very consistent results. Now, by the way, a test can be very reliable. It can give you very consistent results, but not be valid. In other words, it keeps saying I'm a good lover, but in reality I'm not. So it's reliable, but it's not valid. But a test has to be reliable in order for it to be valid. In other words, if the test keeps giving you different results, then how can it possibly tell you accurately that it's measuring what it's designed to measure? So that's an interesting piece. Another thing to keep in mind is clinical utility, and that is it useful? So this test is valid maybe, and it's even reliable, but it doesn't tell us anything useful, so it's kind of a waste of time. So the next slide would be a good one to look at to understand psychological assessments, and this will play into the more formal instruments that we get into, especially with measuring intelligence, etc. So there are different types of validity. So there's content validity, which is the content within the test, measure what it says it's measuring. Convergent validity means does it converge with other things that also are measuring the same thing? In other words, if observers say you're a good lover and the test says you're a good lover and some other criteria says you, then that's convergent validity. All these things agree. Discriminant validity means it's really measuring what it's measuring and not accidentally measuring someone else, something else. So is it really measuring that you're a good lover or just that you're a nice person? Because you can be a good lover but not a nice person, perhaps. I don't know. Maybe those things would correlate. But sometimes it looks like it's valid, but it's accidentally measuring something else. So discriminant validity gets at making sure it's measuring just what it wants to measure. As I said, reliability is making it repeatable, and there are different types of reliability. There's test retest, so you take the test again, does it, or multiple different other times, does it still give you the same result? And inter-rater reliability is, for instance, if different people are watching a video and they're using this rating form to rate what's going on, do all these different raters come up with the same results? Is that reliable? And then internal reliability. So when you have a long test with lots of questions, do all those questions measure consistently with themselves, so within the test itself? And as I said, clinical utility, is it useful? Now, feedback is a very important piece of assessment. In fact, we are required by law to give people feedback. If we give them a test, we can't just say, yeah, you did well. We have to sit down with them, at the very least have a phone call or write out a very detailed report. And here's what happened during the test. Here's what this means. Do you have any questions? We have a legal obligation, ethical obligation to do that. The only exceptions are if we tell them in advance. So, for example, if they're taking these tests as a part of determining whether or not they're going to become a police officer, then we have to say right up front before they start the test, I'm not allowed to give you the results of these tests. I'm giving the results of this test to the police chief or whoever gets them. So they need to know that up front if they're not going to get the results. But, you know, the feedback itself can be a great intervention. In fact, there's a book, probably multiple ones now, that talk about using feedback of the assessment results as an actual intervention. It's informing them about what's going on in their life, and it's not just giving them information, it's helping them. All right, so let's talk about interviewing. Now, you can literally take whole classes on interviewing, and you certainly will if you go on to become a counselor or psychologist or social worker. And, you know, these can be useful skills even in business, all kinds of any interpersonal situation. So one of the first general skills you want to have is the ability to quiet your own mind. And what I mean by that is if you're constantly thinking, what do I ask next? Am I doing a good job? Do they think I'm a nice person? You're not listening. You're going to be in your own way. So you have to be able to be fully present. We'll talk about mindfulness later on. You have to be self-aware, right? How I interact with this person is going to evoke certain responses. So if I'm really cold, they may be cold back with me or angry. If I'm sort of intrusive, they may become defensive. So to be aware of myself and how I interact with people. And we want to be able to develop a good relationship so they'll be open to sharing information. We want to be respectful and caring. And this could end up leading into a psychotherapy relationship at some point, so we want to build a good foundation. Now, again, specific behaviors and skills we want to build. One is just this really listening. I think this culture, especially, when you're talking to somebody doing this the whole time, it can be a lost art to truly listen. So to listen, you want to make good eye contact, have good body language, right? If you're just kind of sitting here like you don't really care, that sends a message. Typically you want to at least be sitting up, maybe even lean forward a little bit. Vocal qualities, of course. You don't want to be shouting at people or be too quiet or sound angry. Your tone will be important. Verbal tracking, meaning that you just kind of repeat back sometimes what they're saying so you can follow what they're saying. And referring to clients by the name they want to be called. And of course, paying attention to cultural pieces too. Some people don't feel it's appropriate to call them by their name or to be addressed as in any certain way. So that's something to check into as well. And of course, they're now cutting the grass right outside my window, so hopefully that won't be too distracting. So doing all those things is one of the things that helps you build rapport, right? And rapport just means having a positive, comfortable relationship between you and the person you're talking to, how you are with that client. You want to build a good rapport, a good relationship. Technique refers to what you're actually doing with the client, and that can be directive or non-directive. Directive is more important in crisis situations or short-term therapy where you want to be very direct and get to what's important. Non-directive style means you ask more open questions and just kind of follow along with where the client wants to go with things. So in that spirit too, open-ended and closed-ended questions, you can be very conscious of how you do that. So if I ask open-ended questions, I may get more spontaneous responses, and I could get a lot more information. So, tell me about what you're dealing with, or tell me about your sleep. Of course, the problem with that is they can go on and on and on, and it takes a lot of time. So closed-ended questions are more specific. How many hours of sleep are you getting each night? Things like that, where you can be much more specific, get the information you need. You just have to watch out, because sometimes clients sit back and say, well, you never asked me about my sleep, or never asked me about this or that. So very often it's a combination, depending on the situation. Now, other tools we have as interviewers, one is clarification. So if somebody says something you don't quite understand, just ask them to clarify. You said you have trouble sleeping. Tell me more about what trouble you have, right? Because for some people it's trouble falling asleep, some they wake up early, some they're up all night long. So just asking for clarification. Confrontation doesn't have to be negative or in their face, but it's just asking about discrepancies. So I might say, at the beginning you said you had a really great relationship with your partner, but now you just said that you can't stand being around them. So tell me more about what your relationship is like. So pointing out the discrepancies and going from there. Paraphrasing is just repeating back, and I remember when I first learned this, it seemed at first to be something that would be embarrassing to do or irritating, but I find it's one of the most powerful things, because it shows that you're really listening, that you're really paying attention, right? So somebody says, I just have no friends. You kind of repeat that back and say, it sounds like you're really lonely, or you've been telling me that no matter how hard you try, you just never seem to be able to, make the connections you want in your life. Even though they just said that, by saying it back, and usually it's better to shift the words around instead of just parroting it back exactly, they know that you heard them. Because if you don't say it back, even though you know you heard them, they don't know that you heard that you heard them, right? So it's just, and don't overuse it, but it can be very helpful for clients. Likewise, reflecting the feeling back, as I just said, you must feel lonely, or yeah, I noticed you looked sad when you said that. Kind of reflecting it back so they feel understood, somebody gets them. And then summarizing can be helpful, so at the end or just certain points in between. So you've been saying you've had a rough time with your relationship, school's been stressful, your things have been stressful at your job. Sounds like you really got a lot going on in your life. Being able to put it all together for people can also be really helpful, and helps make sure too that you understand where they're coming from and what they're dealing with. Now, some practical things about interviewing. One is note-taking, and that is where you have a pad of paper and you're writing down what the person is saying. There's not really agreement on how that should be done. I think when I was a beginner, I did more note-taking, and now I very rarely, if somebody says, this is so important, I want to make sure you write all this down, I want to tell you the medications I'm on, and then I might pull out a piece of paper. But in general, what I find is, having this pad of paper between me and the client, then, it's hard to develop rapport. I mean, the good thing about it is it shows you are really listening, and what they're saying is so important. You want to write it down and make sure you got it. I just find that with experience, I can remember the big picture, most important things, and then I'll write my notes after I'm done talking with the client. Now, if it's for an assessment interview, if I'm doing neuropsychological testing or IQ testing, then I probably will keep a pad of paper, because it's my job to accurately write down all the stuff for the report that I'm going to write later. If it's an interview for potential long-term therapy, I'll come back to details as I need to, or I'll just try to get the big picture, and I won't write things down because I feel like that distracts from the connection I have with the person. So, likewise, some people want to record either through audio or video. When I was a trainee, every therapy room had a video camera, and we hit record, and it was great because as students, we could go into the supervisor and say, watch this and tell me how I did, or if I should have done something differently. The downside, of course, is that it can make clients really nervous to know they're being recorded, and anyway, you definitely have to get permission. You cannot record anybody in a therapy session without their permission, so you clarify that ahead of time, and if they say no, you definitely cannot hit the record button. Now, the interview room is going to depend on a lot of things. Sometimes you're in a hospital, and sometimes you have sort of a roving office. Sometimes you're just doing testing. And, it depends a lot on the culture where you work and the geographic area, etc. But generally, you want it to be professional looking and yet comfortable. Matter of fact, I'm in my therapy office right now, so I'm at my desk where I work, and there's some books I have behind me. So, and I'm not saying mine's the perfect model office or anything, but it's fairly plain. I've got, nature pictures there. By the way, I've read that having just pictures of nature, if you're not by a window, can reduce stress. But, pretty generic. Now, I do have sort of some Asian art there, but you have to be careful. If you put too many things about all your opinions and sports teams, then you might have clients who hate that sport team or don't believe in the same things you believe in. So there's some controversy about how much to do there, but the important thing is think about what's best for your client, and what's going to be most conducive to them feeling comfortable to share a lot of potentially, difficult emotional things. The other practical thing is right at the beginning of the interview, you have to be very clear on the limits of confidentiality. There was once a time when people could say anything they want, and you had to keep it a secret by law. But now, and I guess it was decades ago, someone got murdered and they changed the laws to basically, there are certain limits. So I'll say that right at the beginning when I meet with somebody. I'll say, I'm bound by law to keep what we talk about private, and to keep all your records locked up and secure, etc. But there are some exceptions. One exception is if I feel that there's imminent danger that at any moment you might hurt yourself, or hurt somebody else, a specific person, then I'm obligated to keep people safe. And that could take different forms, but one option would be to break confidentiality and tell somebody about it. The other exceptions, by the way, are child abuse and elder abuse situations that we are mandated to report. And some professions have different limits. For example, somebody once told me they had obligations to report drug use or something like that, whereas I can't do that unless I tell them in advance that I work for this company and our rule is if you use, I have to report it. But as a private practice person, that's all confidential. Now for domestic violence, I have to note it in the record, but I'm not mandated to report that. That could get complicated. If you report it, you could actually make it worse. So they don't mandate that you report that. That's a more complicated issue. But I'll tell clients, sometimes jokingly, to make them feel more comfortable, but I'll say, you could tell me you murdered somebody yesterday, and I am not allowed by law to reveal that to anybody, unless you tell me you're going to murder somebody else tomorrow. So for past offenses, I can't, nobody's in danger of something happening in the future. It's all kept confidential. Now, if you do take insurance, then you have to talk about, I'm going to give this information to what information you're going to give to insurance companies, etc. But literally, if somebody calls me on the phone, even if it's their partner or their child, I'm not allowed by law to say that I know that person, that I'm working with them without the client's permission, and that's best done in writing if they want to give me permission to talk to their doctor or to their family. Let's talk about some of the different types of interviews here, and we'll wrap this up soon. Intake interview is sort of the initial interview. It's deciding, is this going to be a good fit, especially if it's for potential for therapy or you're coming into an agency. Sometimes they have intake people. My only job is to write down exactly what your problems are, and then I decide, first of all, if our agency can handle that kind of problem, and if so, which person to send you to. So it's only meant to gather information and get a quick sense of what they're dealing with and decide what to do with them next. Diagnostic interviews, sort of what we were talking about earlier. It's to just determine what the real problems are, to really get at what's going on. And typically they'll provide a diagnosis at the end. And by the way, obviously we don't have to give diagnoses if there's no diagnosis to be had. And one of the things I enjoy about private practice is I don't have to label people, and I'm pretty privileged that I don't deal with insurance companies. I'd rather drop my fee than hassle with insurance companies personally, because I have just a small practice. So I often don't give people any diagnosis. So to do that, there are a couple options. One is most often a structured interview. I mean, you can have sort of an open interview if you have a lot of experience, but if your goal is to get a diagnosis in a diagnostic interview, you want to have some kind of structure. You want to make sure you ask about, suicidality and the substance use and sleep and all those kinds of things. So it can be nice to have a structure. Some of them are very structured. There's one called the SCID, and Structured Clinical Interview. I don't even remember exactly what it stands for anymore. But that one is very structured and tells you all the questions to ask. And that one's useful for research, just to make sure everybody's going through the exact same diagnostic process to make sure they have the diagnosis that you're looking to research. Semi-structured interview says general questions, but you're free to improvise and get more details. So it might say, how is your sleep? And then I can follow up on questions about sleep and sort of improvise with that. So that's semi-structured. A mental status exam interview is just meant to be typically very quick understanding of, are they oriented to time, place, person, etc. So you might say, do you know what day it is, and do you know where you are right now? And you may or may not ask those depending on how you can pick up if they're knowing those. But short-term memory, perception, you're just trying to get a quick sense of their functioning. Crisis interview is meant to be a very quick intervention. When I say quick, it could take long, but what I mean is you're not just gathering information thinking you're going to see them for a year. You're trying to gather information and help them in the interview itself. So you're not just gathering information, you're intervening. So for instance, if somebody's suicidal, you immediately want to follow up with certain questions. First of all, and there's more detail we could get into about this, but basically, how often, how much are they thinking about suicide? Is it active or passive? In other words, active is, I want to kill myself and I'm going to do it in a certain way. Passive ideation is, if I just didn't wake up tomorrow, or if I got hit by a bus, that'd be okay with me. That's passive suicidal ideation. And then you want to assess, do they actually have a plan? Have they thought about, I just don't want to live, or do they have a plan? So it's more concerning if they say, yes, I'm going to take a gun and, shoot my brainstem. That's very concerning, versus, I don't really know, I thought about taking some Tylenol. It's still concerning, but not as dangerous, of course. Is the means available? So if they say they're going to shoot themselves, but they don't own a gun and they don't know how to get a gun, it's less concerning than if they say they have a gun in their car. And then ask, do you really intend to do it, or are you just thinking about it? And what would keep you from doing it? So if they say, yeah, I think about it, but I have kids and I would never do it because it would devastate my kids, that feels better than they have no reason not to do it. So these are the kind of things you go through in crisis interviews. And last but definitely not least, always think of the cultural components at play when you do interviews. We really have to do our homework if we're going to work with different populations to understand those populations. And by the way, I'm not saying stereotyping. Everybody's different, even within certain cultures and backgrounds. But we want to keep some working hypotheses in the backs of our minds so we don't accidentally make assumptions or misinterpret what they're saying or how they're acting. For instance, something as simple as eye contact. Some cultures don't make eye contact with authority figures. Some cultures look at you when they're talking, but not when they're listening, or vice versa. Some cultures believe or have sort of a sense that you are the authority if you're asking the question. So I don't volunteer information. I just sit here and I don't talk. If you don't ask me the right question, you might not get the information. So anyway, all these different factors, obviously, very important to keep in mind. All right, so that's a quick summary of chapters 7 and 8. And all this is in the PowerPoint slides that I've got up there. And of course, as always, read through the textbook to get even more details. And we'll continue our discussions in the discussion forums.